Welcome back to the Deep Dive. Today we are tackling a truly foundational topic in surgical practice. It's one that really dictates the difference between life and death. And it demands speed and precision, whether you're in the operating room, the trauma bay, or the ICU.
Absolutely. We're talking about the ultimate crisis state, shock, hemorrhage, and transfusion.
And we're diving into Chapter 2 of the 28th edition of Baily and Love.
This is, I would argue, the most critical chapter a surgical learner will encounter early on.
I'd agree.
I mean, the book points it out immediately. Shock is the single most common cause of death in surgical patients. Understanding this chapter is, well, it's non-negotiable.
Completely. And the material is dense, it's comprehensive, and it can be pretty demanding.
It can be.
So our mission today is not to just, recite the textbook page by page.
No, not at all.
Instead, we're trying to interpret it, to create a conceptual framework, a sort of ready reckoner, to make these incredibly complex, time-sensitive concepts sticky for rapid recall. This dive is really for you, the learner, to solidify your understanding before you have to face these crises for real.
Think of this deep dive as your mental blueprint. We're trying to install the essential conceptual anchors.
Anchors, I like that.
Yeah, anchors that allow you to rapidly grasp the underlying pathophysiology, diagnose the specific crisis type, and then, crucially, prioritize your management steps.
And that's everything.
It is, because in a decompensating patient, you have minutes, not hours.
So let's start at the very beginning, that core concept. What exactly is shock in the simplest, most devastating terms?
Okay. Shock is defined as a systemic state of low tissue perfusion.
Low tissue perfusion.
That is the definition you have to anchor to. It's a failure to deliver enough oxygen and metabolic raw materials, primarily glucose, to the cellular machinery to support normal function.
You mentioned cellular machinery. Let's use that factory metaphor from the book. We're usually running these highly efficient factories, but when that supply chain, the perfusion fails, what happens inside that cell factory?
Right. So the cell factories are built to run on highly efficient aerobic metabolism. They take in oxygen and glucose to produce a massive amount of energy, which is ATP, with carbon dioxide as a pretty harmless byproduct.
But when that oxygen delivery stops,
the cell is forced to switch to an emergency, highly inefficient protocol, anaerobic metabolism.
And that's where the toxic waste, the byproduct of that emergency shift, comes in.
Precisely. The product of anaerobic respiration is not CO2, it is lactic acid.
Lactic acid.
And this lactic acid accumulates in the blood, leading to a systemic metabolic acidosis. This accumulation, you see, is the physical manifestation of the oxygen debt.
So clinically, it's a direct and powerful measurement of how profoundly the patient has fallen into crisis.
Exactly. That initial failure is devastating enough, but the source details this cascade of failures that happens when the emergency shift also runs out of fuel.
So what's the immediate physical consequence of that energy failure inside the cell when the glucose is exhausted?
Well, once the glucose is depleted, anaerobic respiration slows down or just stops, and energy production fails completely. The most significant failure at that point is the inability to power the active transport systems.
You're talking about the pumps in the cell membranes.
Specifically, the sodium-potassium pumps.
And without that pump, the whole fluid balance of the cell is completely ruined.
Absolutely. These pumps maintain this very delicate osmotic balance, keeping high sodium outside and high potassium inside.
Right.
When they fail, the cell takes on water, it swells uncontrollably, what we call cellular edema, and ultimately it leads to cell rupture, or lysis.
And when those cells burst, all those highly concentrated intracellular contents, things that are meant to be locked away, are just released into the bloodstream.
Creating all these secondary systemic problems.
What kind of things are we talking about?
You get autodigestive enzymes, pro-inflammatory molecules, and very high concentrations of potassium released into the circulation.
Right, the potassium.
And this sudden surge of potassium causes systemic hyperkalemia, which is incredibly dangerous for the cardiac conduction system.
And I imagine those other enzymes and molecules, they just feed back into the systemic acidosis.
They do. They accelerate widespread organ damage. It's a complete system breakdown, and it starts right there at the molecular level.
Okay, let's unpack this a bit more. We need to trace the systemic failure from that initial cellular crisis outward. Moving beyond the individual cell to the microvasculature, where the real chaos begins to spread throughout the body.
Right.
We've established the failure of the pump, the hyperkalemia, the acidosis.
Yeah.
How does this cellular distress signal what the source calls the leaky pipes phenomenon.
So as the tissue ischemia and acidosis progress, the local environment becomes this potent trigger for the immune and coagulation systems.
So it's moving from a local problem to a global one.
Exactly. It's a global inflammatory state.
Yeah.
Hypoxia activates the complement cascade, and the acidosis, it effectively primes leukocytes, the body's defense mechanisms, to attack.
So the body sees its own damaged dying cell as a foreign threat and launches a full-scale immune response against itself.
That is precisely the mechanism. And this activation results in the generation of highly damaging oxygen-free radicals and the massive uncontrolled release of cytokines.
The body's chemical messengers.
Right. And this inflammatory assault directly damages the delicate capillary endothelial cells lining the blood vessels.
And the consequence of that endothelial damage.
The damaged endothelium loses its structural integrity. It becomes profoundly leaky.
Okay.
Fluid, plasma proteins, sometimes even red blood cells leak out of the vessels and into the surrounding interstitial spaces. That causes tissue edema. This leakiness is really the hallmark of microvascular breakdown and shock.
And tissue edema, that becomes a terrible positive feedback loop, doesn't it?
Mm-hmm.
It makes the initial problem of poor oxygen delivery even worse.
It's a critical compounding cycle. I mean, when that extra fluid leaks out, the distance oxygen has to travel from the remaining capillaries to the struggling cells increases dramatically.
So it's just harder to get the oxygen where it needs to go.
The edema physically exacerbates cellular hypoxia, making it much harder for the limited blood flow that's left to deliver oxygen to those dying factories.
Now, before the system collapses completely, the body, it sort of throws up its emergency brakes, the systemic compensatory responses. This is the stage where the patient can look deceptively stable.
Absolutely. The body has 4 systems desperately trying to maintain core perfusion. Let's look at the immediate responses.
Let's start with the cardiovascular system.
Okay, so the initial drop in circulating volume or cardiac function preload and cardiac output is sensed immediately by the baroreceptors.
Okay.
This triggers an immediate maximal sympathetic nervous system outflow and a flood of catecholamines. Adrenaline, noradrenaline.
And the classic result is?
Tachycardia and aggressive systemic vasoconstriction. The body literally clamps down on non-essential bed skin, gut, muscle to shunt flow directly to the essential organs.
The brain and the heart.
The brain and the heart. And the non-negotiable rule here is that this powerful vasoconstriction fails only in distributive shock. We'll get to that.
Okay. What about the respiratory system? We often see this frantic, rapid breathing pattern. What is that compensating for?
It's compensating for the acid.
The lactic acid.
The primary driver is that systemic metabolic acidosis we talked about, the toxic load of lactic acid. The body attempts to raise the pH by increasing the respiratory rate and minute ventilation.
How does that all?
The goal is to blow off as much CO2 as possible because CO2 dissolves in blood to form carbonic acid.
Wait a minute. If the core problem is acid, the metabolic acidosis, how does the breathing response, the hyperventilation, create a respiratory alkalosis?
That's the key link you have to grasp. By blowing off CO2, which is the acid component of the respiratory system, the lungs create a deficit of acid.
I see.
And that temporarily raises the pH back towards normal. This is the compensatory respiratory alkalosis. This pattern, it often resembles Kussmaul breathing, is the lungs desperately trying to buy time until the underlying perfusion problem is fixed.
Okay, that's a crucial point.
It really is. If you missed that specific link, please take a moment, rewind, and listen to that respiratory response explanation again. Understanding these feedback loops is foundational.
Right. And the renal system, it must be shutting down to conserve volume, right?
Right. The kidney's primary directive is to conserve. Decreased perfusion pressure reduces glomerular filtration, leading immediately to low or absent urine output.
And that pressure drop also kicks something else off, doesn't it?
It activates the renin-angiotensin-aldosterone axis, or RAS.
RAS.
And RAAS causes further systemic vasoconstriction and, crucially, maximum sodium and water reabsorption in the tubules, desperately trying to boost the circulating volume.
And finally, the endocrine system. It's mobilizing powerful hormones to help that sympathetic response.
We see the release of 2 heavy hitters. First, vasopressin, or ADH, is released in response to decreased preload.
And that causes
profound vasoconstriction and water resorption. Simultaneously, the adrenal glands release cortisol.
And cortisol helps how?
It assists with sodium and water resorption, and, critically, it sensitizes the vascular smooth muscle cells to the already circulating catecholamines, trying to squeeze every last drop of compensatory response out of the failing vasculature.
So the body's fought hard, deployed all these mechanisms, but if perfusion isn't restored quickly, we move toward these irreversible states.
We do.
The source first mentions unresuscitatable shock. What physiological tipping point have we crossed when fluids and pressors just no longer help?
This is the stage where the systemic ischemic injury has become too profound, too widespread. The heart, suffering from profound ischemia, which is compounded by severe acidemia and hyperkalemia, is functionally depressed.
So the pump just gives...
It loses contractility and the ability to respond to fluids or inotropic agents. And peripherally, the vasculature is so damaged that it loses its ability to maintain systemic vascular resistance.
The pipes just dilate.
They dilate uncontrollably. Once the patient loses both cardiac function and peripheral vascular tone, physiological exhaustion has set in and death becomes inevitable regardless of what you do.
This leads us to that critical paradox described in the text. Ischemia reperfusion injury, or SIRS. It seems completely counterintuitive. How can the very act of restoring blood flow, the goal of resuscitation, cause further, often catastrophic injury?
It is truly one of the most terrifying concepts in critical care. The injury progresses during the hypoxia, but the major systemic damage is delivered precisely when circulation is restored.
When you reperfuse.
Exactly. Think of the underperfused tissues, especially the gut and the muscle beds, as a sort of toxic reservoir filled with cellular debris, acid, and potassium.
And when circulation is restored, we just unleash that toxic wave onto the entire system.
Exactly. This sudden systemic flush of accumulated acid and excessive potassium causes acute widespread myocardial depression and pathological vascular dilatation.
So you could get another wave of hypotension.
You can. And what's more, the molecules released from the lysed cells activate leukocytes and trigger a massive, uncontrolled systemic inflammatory response syndrome, or SIRS.
And that inflammatory response must be what causes the distant organ injury, like the lung damage.
That's right. This inflammatory cascade and systemic toxicity are distributed by the restored circulation to distant, previously compensated organs.
So that's why we see ARDS, the kidney injury, and so on.
That's why we see the acute lung injury, ARDS, the kidney injury, AKI, and cerebral edema. The defining feature here is that reperfusion injury can only be attenuated by reducing the extent and duration of the initial tissue hyperperfusion.
You have to be fast.
You have to be very fast.
And if we fail to prevent this massive systemic inflammation, we're left managing multiple organ failure, or MOF, defined as the failure of two or more organ systems, carrying that devastating 60% mortality rate.
Yeah. Once a patient is in MOF, management is purely supportive.
What does that look like?
For example, for ARDS acute respiratory distress syndrome, we need mechanical ventilation. For acute renal insufficiency, we require hemofiltration or dialysis. For cardiac failure, we use specific cardiovascular support with pressors and inotropes.
So the goal is simply to support the body until the inflammation subsides, if it ever does.
Precisely. There is no specific cure for MOF, and this just reinforces the non-negotiable rule of surgical shock. Prevention through early, aggressive identification and reversal of shock and the correction of the metabolic markers is the absolute vital priority.
Okay, so the classification of shock is based on the initiating mechanism. And while these states can coexist, and they often get complicated, identifying the primary type is the essential first step that immediately guides your management.
It is.
The pivot point here is understanding how different causes ultimately lead to the same critical endpoint, cellular hypoxia.
And to manage shock effectively, you have to instantly determine where the primary failure lies.
Is it the volume, the pump, the pipes, or the hormones?
Right. And we use the cardiovascular signature, the hemodynamics, as the anchor to classify it. We need to focus on 4 key hemodynamic anchors: cardiac output, CO, systemic vascular resistance, SVR, venous pressure, VP, and mixed venous oxygen saturation, SVO2.
There's 4 markers are the language of shock.
You really are.
Let's start with hypovolemic shock.
Okay. The mechanism is a failure of the volume-reduced circulating volume, or preload failure.
What causes that?
It can be overt hemorrhage, so blood loss, or non-hemorrhagic losses like severe vomiting, diarrhea, or fluid shifting into tissue spaces, what we call third spacing.
Right, like in pancreatitis.
Exactly. The signature is the classic maximal compensatory state, low CO because the tank is empty, high SVR as the body clamps down, and critically, low venous pressure because the system is running dry.
And the SVO2?
Tissues are starting, so SVO2 is also low. The extraction is very high.
Okay, second, cardiogenic shock. The volume is there, but the pump itself has failed.
Correct. It's primary pump failure. The myocardium is unable to generate sufficient stroke volume.
From an MI, maybe.
An MI, severe arrhythmias, valvular failure, or even blunt injury. The signature maintains low CO because the pump is failing, and high SVR as the body tries to compensate.
But here's the distinction.
The distinction is that the veins are often backed up because the heart can't move the volume forward. This results in high venous pressure.
Which you'd see as JVP elevation or pulmonary edema?
Yes. And SVO2 is low because flow is slow and tissues are extracting a lot of oxygen.
Third, obstructive shock. This is where a mechanical impediment stops the blood from getting back to the heart, even if the pump and volume are fine.
This is a mechanical obstruction that drastically reduces ventricular filling. It's a form of preload failure despite adequate volume.
What are the key examples?
Cardiac tamponade, tension pneumothorax, or a massive pulmonary embolus. These are immediate life threats.
And the signature?
It's similar to cardiogenic, low CO, high SVR, and often high venous pressure because the blood is physically prevented from entering the chest. And it's usually very rapid in onset.
Okay, fourth, distributive shock. This is the one that confuses people because the patient can be warm and the cardiac output can be deceptively high.
Right. This is the failure of the pipes to hold pressure.
So like in septic shock.
Septic shock, anaphylaxis, or a high spinal cord injury, which causes neurogenic shock. The primary failure is a pathological, massive vascular dilatation. The pipes are just wide open.
Which means?
This results in a severe low SVR, so low afterload. To compensate for that low resistance, the heart works overtime, sometimes resulting in an abnormally high CO.
And the blood flow is also maldistributed.
It is. It shunts away from the capillary beds.
And this shunting gives us the defining feature for septic shock, the high SVO2. Why is oxygen not being extracted if the patient is in shock?
The high SVO2, which is often greater than 70%, is due to two critical factors. First, microvascular shunting. Blood bypasses the capillary beds entirely and returns to the heart rich in oxygen, completely unused.
And a second factor?
Cellular utilization dysfunction. The septic process, poisoned by bacterial products and inflammation, means the damaged cells can't properly use the oxygen even if it arrives.
So the blood returns oxygen-rich even though the tissues are profoundly starved.
Yes. And this high SVO2 is the crucial diagnostic anchor for distributive shock.
Finally, the source mentions endocrine shock, often complex, like adrenal insufficiency.
Endocrine shock is a severe hormonal failure. Adrenal insufficiency, for example, combines elements of hypovolemia and vascular dysfunction. Critically, these patients often have a profoundly poor response to catecholamines.
Meaning the standard pressors might not work.
They may be ineffective until the underlying hormonal deficit, like cortisol, is addressed.
Let's put this framework to the test. I mean, in the chaos of a trauma bay, or with a deteriorating septic patient, you don't have time to memorize a table.
No, you need pattern recognition.
You have to use these anchors CO, SVR, VP, SVO2 to rapidly categorize the failure.
Exactly. Let's run two fictional scenarios to drill this pattern recognition.
Okay.
First one. A 30-year-old male presents following a motor vehicle collision. He is hypotensive, pale, and tachycardic.
Classic trauma.
Right. But despite receiving 2 liters of balanced crystalloid, he is still hypotensive. And you notice he has distant heart sounds and JVP elevation.
Okay, the JVP elevation is key.
It is. So the question is, you have profound shock. The high venous pressure, the JVP, is the defining feature. Does this point to simple hypovolemic shock from fluid loss or obstructive shock?
Well, simple hypovolemic shock from fluid loss results in low venous pressure. The tank is empty.
Right.
So a trauma patient who is hypotensive and has an elevated JVP that rules out simple fluid loss and signals a central filling problem.
So it points immediately to
obstructive shock, most likely cardiac tamponade, given the distant heart sounds, or maybe a tension pneumothorax.
Exactly. And the intervention there has to be relieving the obstruction, a needle decompression or pericardiocentesis, not just giving more fluid.
Because giving more fluid in a tamponade would just increase the pressure outside the heart and make the filling restriction even worse?
It's life-saving to make that distinction.
Okay, second case study.
An 80-year-old female with known pyelonephritis is hypotensive with a MAP of 55, but she has warm, briskly perfused peripheries. She is confused. Subsequent invasive monitoring shows a high cardiac output and a mixed venous saturation, or SVO2, of 80%.
80%. Okay. So what shock pattern is this, and why is the SVO2 so high when the patient is clearly in shock?
Well, the warm peripheries are the clinical sign of massive vasodilatation, which means low SVR. The high cardiac output is the body trying to compensate. And the high SVO2 of 80% normal is 50–70% confirms that this is distributive septic shock.
Because the tissues aren't extracting oxygen.
Right, due to cellular dysfunction and shunting. The treatment has to address the low SVR with pressors and the cellular dysfunction in addition to fluids. It is not just a volume problem, it is a pipe and cell utilization problem.
Here's the pivot point. Shock isn't always obvious.
Not at all.
The body can be so effective at compensating that it completely masks the crisis until the point of collapse. We have to learn to look beyond the standard vital signs and actively seek out those hidden indicators.
We need to internalize the concept of the hidden danger. Compensated shock, sometimes called occult hypoperfusion.
Okay, what is that?
This is the state where the body is actively reducing flow to non-essential organs, the skin, the gut, the muscles, to preserve the core.
The brain, heart, kidneys.
Exactly. Clinically, the signs may only be mild tachycardia and cool peripheries due to that vasoconstriction, but crucially, the blood pressure is maintained.
So the VP can look fine. Is there any clue in the blood pressure?
Often, the only clue is a narrow pulse pressure.
Explain that. What's a narrow pulse pressure?
The pulse pressure is the systolic minus the diastolic pressure.
Oh.
In compensated shock, massive sympathetic output causes intense peripheral vasoconstriction, which drives the diastolic pressure up.
I see.
And since the stroke volume is slightly reduced, the systolic pressure might be maintained or fall slightly. The result is a narrow gap between SBP and DBP, a subtle but vital sign that massive compensation is occurring.
And what's the danger of this occult hypoperfusion?
The danger is that even though the external vital signs might reassure the clinician, the underperfused organs, the gut, the muscle, are profoundly anaerobic, driving a massive systemic metabolic acidosis.
So they're dying internally.
Yes, and the source emphasizes the devastating impact. Prolonged occult hypoperfusion, so metabolic acidosis despite normal vital signs, for more than 12 hours significantly increases mortality, infection rates, and the incidence of MOF.
Wow.
They are dying internally while looking stable externally.
And then comes decompensation.
This happens when compensatory mechanisms finally fail, typically after a large volume loss, say 30–40% of circulating volume. This is when the blood pressure finally begins to drop.
So what does that look like?
Well, for moderate class 3 hemorrhage, this is the classic point where we see renal failure set in. Urine output falls below 0.5 millifet epi a gay hour. Tachycardia is marked, and crucially, the BP finally begins to fall. Mental status declines. They get drowsy, confused.
And severe shock.
Severe class 4 hemorrhage is a loss of over 40% of volume. You see profound hypotension, they become anuric, so no urine output, and they're unconscious.
Okay, so the clinical signs can be misleading, especially in modern practice.
You have to challenge every assumption, especially with young patients or those on medications.
Let's start with capillary refill time, CRT.
While it's useful in classic hypovolemic shock-cool prolonged CRT, it has limitations. In septic shock, the powerful vasodilatation means peripheries are warm, and CRT is brisk despite profound, life-threatening shock.
So you can't be reassured by a brisk CRT in a warm patient.
Do not let that reassure you.
What about tachycardia?
Well, this expected response may be completely masked. Patients on beta blockers or those with pacemakers can't mount a normal chronotropic response.
But you have to look for relative tachycardia.
You must. A pulse of 80 BPM in a young, fit adult whose normal baseline is 50 BPM is a massive, highly abnormal compensatory effort that must be respected.
And there's a paradox here too, right?
Yes. The source notes the paradoxical bradycardia that can occur in young trauma patients with penetrating injury, which can confuse the picture completely.
Okay, and blood pressure.
We have to repeat this. Hypotension is the latest sign of shock.
Latest.
A fit young adult can maintain a normal BP almost until the final stages of collapse via maximal vasoconstriction.
And you have to consider the patient's baseline.
You do. Relative hypotension is key. For an elderly patient whose baseline is 160/90 millimilli Hg, a reading of 1280 millimilli Hg may seem normal, but it represents relative hypotension and severe hypoperfusion for them.
Right, because their organs are used to that higher pressure.
Especially since their organs require higher pressure to overcome atherosclerotic resistance.
Okay, check-in time. If a young, healthy patient comes into the emergency department after an injury, they have a normal blood pressure, a normal heart rate because of a blow blocker they're taking, but their blood gas shows a profound metabolic acidosis with a lactate over 6 millimol. What stage of shock are they in, and why is this situation so critical?
They're in compensated shock occult hypoperfusion.
Clinically stable, metabolically devastated.
Exactly. It's critical because they are experiencing profound ongoing cellular ischemic damage. If that state is prolonged past 12 hours, their risk of MOF and death skyrockets. The only thing telling you they're dying is the lab work, the lactate, and the base deficit.
If you miss that laboratory signal, you miss the crisis.
You do.
Okay, let's talk about stopping the leak and stabilizing the system. Hemorrhage and shock, they often coexist, but they're not the same problem.
That's a crucial distinction.
The source is clear that recognizing if a patient is actively bleeding determines the entire resuscitation strategy. If they're bleeding, the priority is source control. If they're not, the priority is restoring perfusion.
Right. When major trauma occurs, we immediately encounter acute traumatic coagulopathy, ATC.
Okay.
This is a primary failure of coagulation that develops within minutes in up to 25% of severely injured patients. It increases mortality fourfold.
What does it involve?
Systemic hypofibrinolysis, low fibrinogen, and platelet dysfunction caused by the injury and the shock itself.
And the awful realization is that our necessary resuscitation efforts actually feed this beast.
It's the trauma-induced coagulopathy, or TC spiral, a profound downward spiral.
How so?
We have to give fluids and blood, but these inevitably dilute the remaining functional clotting factors. Secondly, underperfused muscle generates less heat, and giving large volumes of cold fluids exacerbates hypothermia.
Right.
And the final component is the severe acidosis from the shock, which, along with hypothermia, chemically inhibits the function of the coagulation proteases.
So we get the infamous lethal triad of hypothermia, acidosis, and coagulopathy.
And this physiological exhaustion causes uncontrolled non-surgical bleeding and inevitably leads to death.
So the priority shift derived from this understanding is the cornerstone of modern trauma care.
Yes. If the patient is actively bleeding, the priority must be to stop bleeding, not simply volume replacement. Volume resuscitation without hemostasis only worsens the TC spiral dramatically.
It blows the clots and dilutes the factors.
Exactly.
Before intervening, we need to clarify the types of bleeding and how we diagnose if the bleeding is still active, which dictates whether we use DCR or standard resuscitation.
Right. In trauma, we differentiate based on location revealed versus concealed, so bleeding into the chest, abdomen, pelvis. For surgical learners, the timing distinction is also key. Primary is immediate, reactionary is within 24 hours, often a clot dislodges or a ligature slips, and secondary is 7-14 days later, often due to infection.
And the critical difference between surgical and non-surgical hemorrhage.
Surgical hemorrhage is a direct injury that needs mechanical intervention, a ligature, and embolization. Non-surgical hemorrhage is generalized oozing from raw surfaces due to systemic coagulopathy. This requires factor correction, blood products, not necessarily a scalpel.
So how do we dynamically assess if the patient is still actively bleeding, which is the necessary input for deciding on the DCR pathway?
We use the response to fluid assessment. It's a dynamic, crucial measurement.
Okay, what are the categories?
First, a responder. You give a fluid bolus, and you see a good, sustained improvement in blood pressure. The bleeding has likely stopped or was minor.
The goal shifts to full perfusion correction.
Right. Second, a transient responder. You see a temporary improvement in BP, then it drops again. The patient is bleeding, but the rate of bleeding is less than the rate of your volume administration. They need intervention.
And the third?
A non-responder. No improvement in BP despite fluid. The rate of hemorrhage is greater than the rate of volume administration. They need immediate, definitive control.
The key insight here is
both the transient responder and the non-responder are actively bleeding and require rapid control of the source.
Okay, so this leads us to the damage control resuscitation, or a DCR paradigm. This is a radical shift from the old standard of trying to achieve normotension at all costs.
DCR is the modern paradigm for the actively bleeding patient. It prioritizes coagulation and source control over immediate, absolute normoperfusion. It's based on 4 critical pillars.
What's the first pillar?
Rapid hemorrhage control. This is always the first move. Direct pressure, tourniquets, internal packing. The immediate goal is to actively move the patient to definitive control, the OR, or interventional radiology.
And this is coupled with damage control surgery.
Yes, DCS, where the intervention is limited to the minimum needed to start bleeding and control contamination.
The anchor here is like a badly damaged ship.
Yeah.
The goal is survival and basic function, not a complete cosmetic repair.
Exactly. Definitive reconstruction is delayed until the patient is warm, pink, and clotting.
The second pillar is permissive hypotension. This is the most challenging concept for new learners.
It is. While the patient is actively bleeding, we allow them to run hypotensive. We target a MAP of over 50 mmHg, or just enough to maintain a palpable central pulse.
Permissive hypotension still feels counterintuitive. If we are trying to fix cellular hypoperfusion, how can allowing a low pressure for the brain and kidneys ever be the safer choice than trying to restore normal pressure immediately?
That's an essential question because you're weighing the immediate systemic need against the local risk.
Right.
The justification is twofold. First, restoring high pressure, or normotension, before the hole is plugged, can dislodge partially formed clots. We call this popping the clot.
And that causes massive renewed bleeding.
It does. Second, aggressive volume replacement to achieve normotension requires massive amounts of clear fluids, which fatally worsens the dilutional coagulopathy and hypothermia, driving that lethal triad.
So we are accepting temporary mild organ hypoperfusion to prevent uncontrolled hemorrhage and terminal coagulopathy. It's a calculated risk management strategy.
Precisely. You sacrifice normotension now to ensure the patient clots later.
Okay, the third pillar must be about the fluids themselves.
It is. Avoiding dilutional coagulopathy. We must avoid clear fluids, crystalloids, colloids, as much as possible, as they dilute factors. Instead, we give a balanced transfusion that approximates whole blood.
What's the ratio?
Ideally, administering red blood cells and plasma in a ratio of 1.1, sometimes with platelets in a 1.1:1 ratio.
And the fourth pillar?
Treating existing deficits. We treat the existing coagulopathy immediately and empirically. We give tranexamic acid, or TXA, as soon as possible to stop hyperfibrinolysis. Then we use specific factor concentrates guided by point-of-care testing cryoprecipitate for low fibrinogen, for instance.
Okay, so once the bleeding is controlled, or if the patient is in non-hemorrhagic shock like sepsis or cardiogenic shock, the strategy immediately pivots.
It pivots from damage control to perfusion-targeted correction.
So the standard ABCs apply: airway, breathing, then circulation.
And in circulation, correcting preload, the volume, is always prioritized before starting vasopressors or inotropes.
We stress the rule: never administer pressors to an empty heart. Why is fixing the volume deficit first so crucial?
Well, starting pressors in a hypovolemic patient increases afterload massively against an already depleted ventricle.
So the heart is struggling to fill, and now it's facing immense resistance,
which quickly and permanently depletes the myocardium of oxygen stores. Reducing coronary perfusion and contractility, you essentially exhaust and stop the heart.
Regarding access, the physics of fluid flow applies directly here. Wide and short is better than long and narrow.
Absolutely. For rapid volume replacement, you need short, wide-bore peripheral catheters, 14 or 16 gauge. Central lines, while they're great for monitoring, have greater resistance due to their length and narrow lumen.
So they're poor for high-volume, rapid infusion.
Very poor. Time is perfusion.
Now, fluid choice. The text notes the ongoing crystalloid versus colloid debate.
For non-hemorrhagic shock, crystalloids like saline or Hartmann's are the standard. The key insight from the most recent evidence is that there is no overt difference in patient outcome between crystalloids and colloids.
So things like albumin or starches.
Right. Colloids are expensive, and the volume benefit previously touted is minimal. Consequently, crystalloids remain the first-line choice. You just want to avoid hypotonic solutions unless you're treating pure free water loss.
Finally, when do we bring in the big guns? Vasopressors and inotropes.
Only after adequate preload is established.
Right.
Vasopressors, like noradrenaline, tighten pipes. They're used primarily in distributive shock sepsis, neurogenic, where SVR is pathologically low despite adequate or high CO. Inotropes, like dobutamine, strengthen the pump. They're used in cardiogenic shock or complex septic shock with documented myocardial depression to increase cardiac output and thus oxygen delivery.
We've stabilized the patient, controlled the source, started volume correction. But the most difficult judgment call remains. knowing when to stop resuscitation.
Yes.
This requires advanced monitoring to catch that deadly state of occult hypoperfusion.
The minimum standard of monitoring HR, BP, urine output is often preserved until it's too late. We have to seek out global indicators of cellular function.
So what are the invasive monitoring tools that give us a better picture of volume status and pump function?
We use CVP, central venous pressure, and cardiac output monitoring. CO monitoring helps classify the shock type and guides your inotrope or pressor therapy.
But CVP is often misinterpreted.
It is. It is a poor reflection of preload alone. The source states there is no universally normal CVP. It has to be assessed dynamically.
How do you dynamically assess CVP using a fluid challenge?
The fluid challenge involves giving a small bolus, say 250, 500 millirel rapidly. A normal fluid-responsive patient will show a transient rise in CVP of only 2 to 5 centimilli H2O.
And if it goes up and stays up?
If the CVP rises sharply and stays high, it means the patient has high preload and cannot handle the fluid, indicating probable cardiac insufficiency and potential volume overload. This dynamic assessment is vastly superior to a static CVP number.
Ultimately, the goal is to restore cellular and organ perfusion. And the best global measures, the ones that catch the occult crisis, are the metabolic markers.
The direct measurements of oxygen debt. Precisely. We focus on base deficit and lactate. Lactic acid accumulation is the physical proof of anaerobic metabolism. A base deficit greater than 6 millimol is a powerful signal of high morbidity and mortality.
So resuscitation is insufficient until those markers are actively normalizing, regardless of what the blood pressure is doing. Then there is the highly complex indicator, mixed venous oxygen saturation, SVO2, which tells us about the balance between oxygen delivery and consumption.
Right. SVO2 measures the percentage of oxygen returning unused to the right heart. Normal is 50–70%. A value less than 50% indicates inadequate delivery. The tissues are desperately extracting every last molecule of oxygen.
Typical of hypovolemic or cardiogenic shock.
Exactly.
And the high value, the signature of sepsis.
A value greater than 70% is the defining feature of distributive or septic shock. As we discussed, this signals disordered utilization and shunting. The oxygen is available but not being used.
But let's look at the clinical relevance here, because this often trips people up. If a septic patient whose target is over 70% VO2 registers at 60%, they look numerically better than the hypovolemic patient. What does that 60% reading tell the clinician?
It means they're experiencing relative hypoperfusion. While 60% might be normal for a healthy person, it is dangerously low for a septic patient whose cells can't use oxygen effectively.
So their oxygen delivery is insufficient even for their utilization-impaired state.
Correct. They require more aggressive therapy fluids, inotropes, or pressors to push that SVO2 back above the septic target of over 70%.
This brings us back to the endpoints of resuscitation. Why is stopping when BP and HR are normal the most dangerous trap?
It leads straight into the occult hypoperfusion trap. You've restored perfusion to the preserved organs, but you are still underperfusing the gut and muscle beds. That damage continues.
And when blood flow does eventually return to those damaged beds, the systemic SIRS and reperfusion injury hits.
It does. The target must be normalization of global perfusion endpoints: base deficit, lactate, and SVO2. Failing to normalize these markers for more than 12 hours dramatically worsens outcome and guarantees MOF.
Okay, let's shift to the science and risk of transfusion.
A necessary evil. Blood is a limited resource, and the transfusion of heterologous blood carries an immunological price.
What do you mean by that?
It leads to increased morbidity and sometimes decreased long-term survival in trauma, malignancy, and other conditions. We have to be judicious.
Let's quickly review the primary components and the changing practice for when we transfuse.
Okay. We have packed red cells, PRC, for oxygen delivery. Fresh frozen plasma, FFP, rich in coagulation factors, which is the first line for coagulopathic hemorrhage in DCR. Cryoprecipitate, which is derived from FFP and is highly concentrated in fibrinogen. We give that for low fibrinogen states, which are universal in trauma.
And platelets.
Platelets have a short shelf life, 5 days. They're essential for thrombocytopenia or platelet dysfunction. And then there are prothrombin complex concentrates, PCCs. These are the high-stakes tools used for the immediate emergency reversal of oral anticoagulation like warfarin during uncontrolled hemorrhage.
Moving on to the trigger. The change in transfusion thresholds is one of the most critical updates in recent surgical practice.
It is.
We used to transfuse everyone to 10 GDL.
That practice has largely been abandoned because it showed increased morbidity. The current paradigm is highly restrictive. A hemoglobin level of 6 GDL is generally acceptable in asymptomatic, non-bleeding patients who are not facing major surgery.
So what's the general guide?
Less than 6 GDL, there's likely a benefit. Between 6 and 8, it's unlikely to benefit unless they're actively bleeding or about to have major surgery. And over 8 GDL, there's usually no indication.
Okay, now compatibility. The systems we must know inside and out.
The ABO system is determined by antigens on the red cell and naturally occurring antibodies in the serum. Group O is the universal donor because it has no antigens.
And AB is the universal recipient.
Correct. No antibodies. The danger of ABO incompatibility is catastrophic. Rapid, complement-mediated intravascular hemolysis leading to acute renal failure and death.
And the rhesus-D system, which is critical for women of childbearing age.
The RHD antigen is present in about 85% of people. Antibodies to RHD are not naturally occurring. They're acquired through prior transfusion or pregnancy.
And that's the key risk for RHD-negative mothers.
It's essential because subsequent pregnancies with RHD-positive fetuses risk severe hemolysis in the baby or hydrops fetalis.
In an emergency, time is ticking. How long does the cross-match take, and what is the emergency option?
A full cross-match takes 45 minutes. A type-specific match, so just a bore, takes 10-15 minutes. In a dire emergency, we use emergency blood, Group O.
Specifically, O-negative for women of childbearing age to prevent sensitizing them, and O-positive for men.
Exactly. And the source strictly mandates the essential protocol to prevent fatality. 2 healthcare personnel must independently check the patient's details, the prescription, and the donor blood label.
Finally, let's detail the 2 major categories of complications: single transfusion and massive transfusion.
Okay. With a single transfusion, beyond the fatal acute hemolytic reaction, we worry about febrile reactions and, critically, Turelli.
Transfusion-related acute lung injury. What is the clinical picture there?
Turelli is sudden, non-cardiogenic pulmonary edema occurring within 6 hours of transfusion. It mimics ARDS. It's often caused by antibodies in the donor plasma reacting with the recipient's white cells, causing massive inflammation and capillary leak in the lungs.
And massive transfusion complications.
These are due to the volume, temperature, and storage medium. They include coagulopathy from dilution, hypothermia from cold blood, and electrolyte abnormalities.
Which electrolyte is most common?
The most frequent is hypocalcemia, caused by the citrate anticoagulant in the stored blood binding to and chelating the patient's circulating calcium. This can cause cardiac instability, especially during high-rate transfusion.
And the management of coagulopathy circles us right back to DCR.
It does. The 1.1.1 ratio is central to prevention. If coagulopathy is established, we treat empirically with TXA and then use laboratory-guided correction, most commonly cryoprecipitate, to replace fibrinogen to stabilize the clot function until definitive hemostasis is achieved.
So what does this all mean? It means surgical resuscitation is a tightly controlled dynamic race against physiological exhaustion. The strategy has to be dynamic and fluid, shifting rapidly from an uncontrolled bleed scenario, which is DCR, permissive hypotension, balanced blood products, to a perfusion-targeted correction-normalizing lactate and SVO2 once the source of the bleeding is fixed.
And misdiagnosing the stage or type of shock leads directly to the wrong treatment and exacerbates the spiral toward MOF.
Okay, let's wrap this up.
The concepts of shock and hemorrhage are foundational, not just for surgery, but for all of critical care.
Absolutely.
We have provided structure and clinical anchors, the high SVO2 of sepsis, the critical difference between high and low venous pressure, the narrow pulse pressure of occult shock, and the deadly Tillich triad. But please remember, this deep dive is a blueprint. The source material, Baily and Love, contains the detailed specifics and nuances you need for true clinical mastery. Use this outline as a map, but ensure you dive back into the chapter for the detailed mechanisms.
We covered everything from the failure of the sodium-potassium pump and the deadly triad to the justification of permissive hypotension and the necessary caution around Turelli and citrate toxicity. This is information you just have to internalize to be an effective, safe clinician.
You do.
So a final provocative thought for the learner. If aggressive crystalloid resuscitation, even in non-bleeding shock, can lead to dangerous consequences like tissue edema, pulmonary injury like ARDS, and abdominal compartment syndrome, how might future surgical management further refine permissive hypotension parameters to balance adequate systemic perfusion against the risk of fluid overload in non-bleeding shocked patients?
That's a great question.
When is being empty enough actually better than achieving normovolemia? It's a fundamental question about balancing risks, and it's something to mull over and discuss on your rotations.
We appreciate you trusting us with your deep dive.
We'll see you next time.